Hi, this is Jean Abbott with an introductory video for providers about advanced care planning and things that we need to do with our patients to make sure that their wishes are being honored near the end of life. So, why has this become a big deal lately for medical practice? Dying these days happens in so many different ways, many more than used to happen. And our patients have become much more diverse in terms of their values and their wishes at the end of life. All of us, I think, as providers, feel that the end of life is an important part of the journey in caring for patients. And so we want to do it the best way that we can. And the best practices for helping people achieve the kind of end of life that they wish are becoming more clear and have evolved over the last decade or two. And more important practically, medical care providers can be reimbursed by Medicare, which has recognized that advanced care planning is an important component that should be able to be billed and should happen almost as a procedure. Here's a look at the way that our dying trajectory has changed. 100 years ago, 90% of people died suddenly over days, weeks. But these days, only about 10% of people die abruptly. The other three trajectories are about 30%, 30%, 30%. And you and I know patients who are probably in each of these trajectories. The terminal trajectory of end-stage cancer is a pretty predictable 6 months, and that's actually how hospice got started and the hospice funding uh, proposals, because the predictability of end-stage cancer. But we see as many patients who have this organ failure trajectory where we see exacerbations, we rescue people, another exacerbation, we rescue people. They never get better than they were before the exacerbation. And actually, the time when we can't rescue them is sometimes sudden and abrupt to both patients and families. The third trajectory that we see commonly is that of frailty. This is the patient who is very elderly, very frail, often with dementia, and their dying process can actually take place over 5 or 10 years even. Despite the fact that only about 10% of people die abruptly, most of us want to die in our sleep or rapidly and painlessly. This is a recent survey from the New York Times. I like it because it demonstrates that over 80% of people want to die abruptly. I also like it because in their survey, 1% of people wanted to die having sex and being shot by a jealous spouse. This is a study from JAMA a couple of years ago, and it demonstrates what an acceptable life is varies greatly. It also changes over time. The economists took the data from this study and actually made it much more pretty in a graph like this, which is a little complex, but the line in the middle is equivalent to death. And what they did was they took a bunch of sick 80s elderly people in the hospital and they said, so tell me, would living in a nursing home, would being intubated be worse than death or acceptable to you as an alternative to death? And notice how different people are in terms of their take on these things. Half of people say that being intubated and on a ventilator would be worse than death, but half of people think that would be okay. And you can go down the list. In a wheelchair, most people say, yeah, that would probably be okay, and that would be better than death. But we vary as a society, and our patients vary, and only by asking them do we know what exactly would be a fate worse than death and what would be an acceptable compromise for them. The whole healthcare spectrum, from institutions to providers to patients, really has some work to be done in terms of improving end-of-life care. The Institute for Healthcare Improvement, a think tank that works on quality issues, has issued their second white paper on how hospitals and providers need to be conversation ready. That is, ready to receive the wishes and understand what matters most to their patients. And in fact, when institutions and providers fail to respect patients in terms of their wishes at the end of life, it's now being understood as a preventable harm or even a medical error, just like not noticing that somebody has an allergy and writing a prescription for an antibiotic that somebody is allergic to. And thus, it's also considered a safety issue. So advanced care planning is actually more than forms to hand to the patient, although that in our busy provider world is certainly the easiest thing. It turns out that what patients want oftentimes is not specific procedures that they do or don't want, and those are in the checkboxes that we usually have in our written documents. Instead, what's most important oftentimes is to not be a burden, to maintain some control, and to avoid suffering. And it's hard to know in the future what that is going to look like because the situations and exact circumstances people find themselves in is really not very predictable. So really the thrust of advanced care planning in its best form is to have conversations and for the healthcare system to understand what matters most to patients, that is their values, rather than the specific checkboxes and procedures. Over my years as an ethics consultant at hospitals and hospices and long-term care facilities, there are lots of times when providers, patients, and their families sort of blow this off and say, you know what, when something happens bad, we'll sort it out then. And that just doesn't work because over 50% of people near the end of their life will not be able to participate in decisions. They will not have decisional capacity. Ellen Goodman, who started the Conversation Project, which we'll talk about later, says it's always too early to talk about advanced care planning in the end of your life until it's too late. In addition, we live in a healthcare system that is very siloed, and so your patient, if you're an outpatient doc, is unlikely to be managed by you in the time of a crisis when they roll into the emergency department and when they roll into the ICU. We're also starting to understand much more that the burden of surrogate decision making, making a decision for your loved one, can be really stressful and can have long-term sequelae, particularly when you haven't had conversations with your loved one about what's important. Here's one of the Likert scales from the Conversation Project Starter Kit, which is one mechanism for patients and families to talk about what's important to them near the end of their life. This one is, what are your concerns about treatment? And I'm sure that you have patients who are worried that they will get overly aggressive care, and probably also patients who are worried that they won't get enough care. Another example of the differences that you need to understand and your patient needs to be able to share with you. Frankly, this is hard stuff for us to talk about with our patients. There are some interesting studies that show that the longer you've been caring for a patient, actually the more optimistic you are in terms of their prognosis, including being over optimistic. We didn't get a lot of training, or at least I sure didn't, in medical school about this important part of medical care. And it really does take time to do well and completely. And you and I have a long list of things that we're supposed to cover with our patients during even a well patient visit. This is an interesting study of hospitalized general internal medicine patients, and almost everybody wants to participate in having their opinion considered and in the choices that they want to make at the end of life. But interestingly enough, 2/3 of them ultimately want to defer to their provider. We think in this society where autonomy is so worshipped that it's the patient's decision, but no, they need us for guidance and they want us for guidance. This is a really crucial overview graph of what's become the best practices around the country. It started with Bud Hammis and a group in La Crosse, Wisconsin. He, over 20 years, has conceptually developed the arc of advanced care planning over various stages. And we're going to review this because it's important for all of us to understand it in the planning that we do with our patients in the office and even when they're in the hospital. So, what do these stages of advanced care planning look like for you and me as providers for our patients? Early advanced care planning is planning when you have well patients, whether that's people that are adult, whether it's over the age of 30 or 40, or whether it's people who are 65 and older. What's most key for everybody is to have assigned an agent who has their medical durable power of attorney. This document assigning an agent is in the green blue book that many of you have that talks about your right to make healthcare decisions and is from the Colorado Hospital Association. Everybody needs to think about what's important for their values, and they need to think about who would speak for them if they fall down the stairs and donk their head, if they ski into a tree well and can't think straight, or if they mountain bike, as so many people do in this county. So everybody needs to think about who would be their agent and what's important to them at this point in their life, even though we know that that will change. This may not require a billable visit. In fact, it oftentimes doesn't even require a provider to do this, but this should be part of the office practice to say, it's important to us to know who would speak for you if you can't, and we need to get this into the record so we would know in an emergency. It's important to explain to your patients why assigning an agent with the MDPOA is so important. In Colorado, if you don't choose an agent and some backups, we as providers, if you're in the ICU or in the emergency department and can't speak for yourself, are obligated to gather together the interested parties, interested people in your life, and that includes all family members who have an equal seat at the table, as well as close friends who care about you. This is called the Interested Persons Statutes. It's an unusual one, but is true in Colorado and was actually started in the 1980s, which is the time when the HIV epidemic was just starting, and when there were a bunch of people who were HIV positive, had partners who weren't recognized legally, and who may have been estranged from their family. So we don't have that hierarchical system that is in the law of most states. And your patient needs to choose somebody. There are worksheets to help you, but you need to choose someone who knows your values, who is accessible and not trekking in Patagonia 6 months of the year, and can imagine life without you. That's a particularly important one because there are lots of 85-year-old couples who just can't imagine life without their spouse, and it would be very stressful for them sometimes to be your agent. So how do you do early advanced care planning? This can be done by your staff. Oftentimes people, as they're being ushered into the room for their exam, can be asked something like, have you ever thought about who you would want to speak for you if you couldn't speak for yourself? And your aide or your nurse can ask if patients have an advance directive. We need to see this. We'd love to, and we'd love to scan it into your chart. The team should be encouraging patients to think about what's important to them. There are several tools about this, and we will be posting those as part of this module. But there is a pamphlet that has Colorado documents in it. It's green and blue, your right to make healthcare decisions. We have a proxy worksheet that is very helpful to think about who you would want to be your decision maker. There is a starter kit from the Conversation project that helps people play with thinking about what's important to them. And it can be a cover note from your clinic talking about how this is important and how people should share that with their provider's office. Okay, how about the patient who has just been discharged, or you're sitting and doing discharge planning? They've had a GI bleed from their cirrhosis. They've been extubated after a complication of their COPD. They've just had an episode of acute heart failure and have been stabilized. You're either getting a post-discharge visit or at discharge from the hospital, sitting down with the patient as as a hospitalist? Do you have an MDPOA? Have you talked with your family and your agent as well as other people? Do you understand the diagnosis? Let's talk a little about the trajectory and the prognosis and what treatment options. What's going to happen the next time your COPD flares? Are you okay with being intubated if that's necessary? Those kinds of serious illness next steps in advanced care planning are in some systems done by a nurse or a case manager in your system. Doesn't necessarily have to be the physician, although certainly understanding and reviewing what's important, particularly as it might change, is part of the conversation that needs to be had. In the arc of advanced care planning, late steps is something that happens for patients with advanced serious illness. At this point, the provider needs to take the initiative, and it's going to take time. This is certainly one of the places where a billable Medicare visit of whatever length would be appropriate, either with the patient, with their surrogates, but it's important that the provider be the initiator and clarify patient values and wishes. This is the time when you pull out the MOST form, the green form that translates people's values and wishes into orders based on their current medical status, not projecting into the future, not hypothesizing, I don't think I'd want intubation, but now with COPD at this stage, I don't want to be intubated again, or I don't want to go to the hospital. And the MOST form is sometimes required in residential settings, although it's not legally allowed to be required, but it takes these values and translates them into direct orders that you sign and your patient or surrogate signs. We may develop another module about MOST forms because there are complexities to them, but it is important for you to pull them out and take a look at them. As an ethics consultant, both in this state and in talking with people around the country, these forms are being misused. They're being given to healthy people at their 65 Alive visits when it's impossible to know whether you're going to want CPR or whether you're going to want intubation, when this is in the abstract and in the future. We also see the problem that part of the issue is that they're not being honored by EMS or in the ER. I've had one ER colleague say to me, well, it's my job to try to resuscitate them, and if I succeed, they can sort that out upstairs. That's not fair. You are protected from liability when you honor valid MOST form orders, even if that includes not resuscitating or initiating life-sustaining treatments. Oftentimes, these forms are being not thoughtfully discussed by providers. They are being rotely signed, like radar shoving it in front of the colonel on MASH. And oftentimes they're being done with the family not aware that the patient has a MOST form and therefore overruling it. They aren't supposed to be able to overrule, but it's really hard to not overrule if indeed you don't know that the patient didn't want a lot of interventions. Okay, so here's the summary. What are the provider roles in advanced care planning? The first is you've got to ask, who do you want to speak for you near the end of your life if you can't? Have you talked to them about what's important to you? You need to grease the skids so that somebody in your office or the patient themselves with their families knows that this is important to you, and you can give them some materials that will help them work through some of the important values inventories that will help everybody when the patient can no longer make decisions. And then you need to figure out a way through your electronic health record or your office to flag any discussions and close the loop so that you get the MDPOA entered into the chart and enforce with the patient that it's important for me to know what matters to you now, even knowing that that'll change as you get older, sicker, whatever. You do need to document these conversations, and we're working with Epic to try to figure out an easy place that this information and these conversations can be accessed, not just the documents, but the thinking behind them and the conversation behind them. Remember that you can bill for this at any stage, from healthy people to sick people, to people near the end of their life, for whatever length of time you have the conversation, and it can be with surrogates or with patients. And then in late advanced care planning, you are going to need to be the initiator of a MOST form to help with orders that may prevent unnecessary hospitalization or resuscitation if those are the patient's values. We will attach the IHI forms for what the rules of the road are for billing for advanced care planning, but they include fairly robust support for you making this an important part of the activities you do with your patients. Advanced care planning is not as easy as it sounds like when I give you a lecture about what would be best practices. There are still huge challenges remaining, but it's becoming more standard that this is part of best practices for caring for our patients and accompanying them on the journey near the end of their life. There's starting to be challenges that say it's a medical error when patients get resuscitated, when they have clear requests not to get attempted resuscitation. But we understand there's a time crunch in the clinic, so figuring out strategies for focus groups or use of your support staff are very important. It's still a challenge to get the documentation where you need it to be so that it is available readily to the emergency department, to the ICU, and to other people who might be caring for the patient besides you. It's also important that these documents and discussions get updated, and figuring out a place where these updates are readily accessible also. And another challenge is engaging the family. We are so used to talking to just the patient that it's a little bit difficult to figure out how you're going to either pick up the phone or bring the whole family in to have these conversations so that everybody is on the same page and isn't surprised when these downturns occur. Practice helps, and it's important to normalize these kinds of conversations for our patients. Each clinic will have a different method of operationalizing the flow of work and documents through their clinic and into the charts, and following through with patients as they progress through life and through significant illnesses. The Care Network is committed to trying to find some good flow solutions and to follow through and see how this is working in your clinic. So we look forward to the ongoing conversations and problem solvings with you all.